some ancient chimpanzees, and all sorts of monkey species. So you can decide for yourself where you think herpes came from. But if you look at the history of herpes, the word literally means to crawl or creep. And it comes from ancient Greek. And the first person to describe the cold sore was Roman physician Herodotus. And in 1736, they coined the term herpes. John Astor coined that term. And then in the 18th century, it was denoted as a vocational disease as it was seen more prevalent in sex workers. But in the 19th century, it was found that it actually was transferable beyond just these sex workers. And in the 1940s, they first discovered that this was actually a virus that was causing this disease, and the two serotypes were actually described in 1960 later on, and it was found that this virus was coming from a herpes viridae family, which we'll discuss later. So what we currently know about herpes is that it is a prevalent viral infection which stays lifelong and causes frequent outbreaks in the human body. It's caused by type 1 and type 2 herpes simplex virus, which is both common in pregnancy. And a study done by Delaney found that actually over a 20-odd year span, the prevalence of herpes type 1 increased slightly to 69%, and herpes type 2 decreased from 30 to 16% due to the safe sexual practice program that was rolled out. Neonatal herpes, which is very rare, which we'll discuss briefly later, has remained the same over the years in terms of prevalence. Immunocompromised individuals are the most susceptible to this infection, and we currently don't have any prophylactic or therapeutic vaccines. As far as HSV1 is concerned, we know that it is mostly acquired during childhood and transmitted via direct contact with infected materials, and it can affect the genital area as well. So it's not only type 2 that affects the genital area, but also HSV1. HSV2, on the other hand, is transmitted through sexual contact and increases the risk of HIV transmission. And women are twice as likely to get infected as men seem to be more effective in actually transmitting the virus. So now let's look at the virology briefly. We'll try and move quickly through it. So it has 4 layers, which we'll discuss shortly. So herpes belongs to the Herpes viridae family. It's a genus simplex virus. It has 3 subfamilies, the alpha, beta, and gamma. It shares 82% sequence homology in terms of its genomic structure. And the first part of the virus is a virion, which comprises the genome of the virus. It's a double-stranded envelope DNA core. And secondly, the icosahedral capsid, which has 4 viral proteins. VP5 is the major one. It basically helps the virus to be guarded. It guards the viral DNA outside of the host, and it helps initiate the infective process. The tegument has 22 viral proteins, which modulate the viral and host protein expression and virus assembly. And then we have an envelope lipid bilayer membrane, which contains 12 glycoproteins, which influence the B cell response and also facilitate viral entry, which we'll also look into just shortly. So to the right is the structure as has been described. So if you look at the picture to the right, you can see there that the envelope will produce those glycoproteins, and D, B, C, H, and L are the major proteins. And in effect, when they get into the host cell, the epithelial cell initially, they will basically interrupt the innate as well as the adaptive immune responses. They will also facilitate viral entry and proliferation of the virus. If you look at the tegument, it will secrete also some viral proteins. And of interest is that VHS protein there, the viral host shutting protein, which inhibits the cell RNA synthesis mechanism, thus reducing the competition for the virus in terms of, producing its own proteins within the cell. And this then supports viral proliferation instead of the cell's protein, and also enhances the viral virulence and blunts the immune response further. So if you look at the pathophysiology, HSV1 and 2 are through contact with one, is contact with the saliva near the mouth that has been exposed to the virus, as an example, or any infected material. And type 2 would be sexually transmitted through contact with anal, genital, skin lesions or fluids of an infected person. Although HSV2 can spread even if even in an asymptomatic individual with normal skin, but basically the virus would penetrate through breaches in the skin surface mucosa and eventually gain access to the neurons that innervate that particular area, and then stay there lifelong as a lifelong invasion in the peripheral neuron cell bodies and the sensory autonomic ganglia by a term that they call a parasitizing axonal transport. And it will move through an infective and latency sort of phase, which is the so-called lytic phase and latency phase. And if you look to your to the right of your screen, you will see there that the virus would basically come in, attach, and then fuse with your cell membrane. And if you look there at point C, the caspid then would be would transport would be transported to the cell nucleus, and then where you'd get your transcription, which will start off, and your translation, and then your replication. Capsid assembly will then proceed. And then you have your glycosylation there at point H down there by the Golgi. And then you have primary envelopment of the virus. And then you would have your glycoprotein transport to the cell surface. And then you have your secondary envelopment, and then endocytosis, and eventually you'll have release of your new virus that has been formed. So what is important to note about herpes simplex is that it does not integrate with the cell genome. That is something that is different about it. It's non-integration with the cell genome. It exists as an epichromosomal structure. That's how it establishes its lifelong, so its latency, where it can live in your body for basically the rest of your life. So there's just to the right a picture showing that it will go settle in your neurons and then travel back to the epithelial cells, infect them, causing that lytic phase of the virus, infect the epithelial cells again and again, switch back to dormancy. And actually, it's not known exactly how it establishes this cycle without actually destroying your neurons and actually living their lifelong. It's something that is being researched. Then here it's just to show that the virus would infect an individual through an ascending infection, in particular in pregnancy, compared to your other viruses, such as, for example, the cytomegalovirus, which would be spread through transcytosis through receptor expressions. But the herpes simply is an ascending infection in essence. So what we do not know about the virus is how Father Christmas caught it, but you can actually send me a message and tell me if you figure that out. So in this talk, we've dealt with the pathophysiology and the history. So we'll look at the epidemiology, risk factors, diagnosis, classification, and clinical staging, treatment modalities that are available, vertical transmission. We'll look at issues around management in pregnancy, a bit on disseminated herpes and neonatal herpes. So Herpes type 1 and 2, herpes type 1 affects 67% of the population, and type 2, 13% of the population, which is 3.7 billion people under the age of 50 and 491 million people between 14 and 49, respectively. 30% of herpes type 1 infected individual will have repetitive oral labial infections annually, and 40% will have frequent infection annually of HSV2. And HSV2 would have 3.6 million new cases annually, which are reported. It's the prevalence is higher in women, but lowest in the European population and highest in the sub-Saharan population at 70%. But neonatal herpes is actually a very rare entity with a prevalence of only 10 per 100,000, which is quite rare. So locally, there's limited data, but the data that is available shows that the prevalence of HSV2 is 40 to 70%. And 1% of women who are seronegative will actually seroconvert during their pregnancy for HSV2. There is currently no HSV screening that's done routinely as per standard of care. But we are aware that exposed infants are at risk of neonatal mortality should they succumb to neonatal HSV. If you compare a third world such as ours and the first world such as the US, you'll see that the seroprevalence there's a huge difference between the seroprevalences, with us sitting at 30 to 70% and the US sitting at 21%. And if you look at 100 people over a span of a year, then you'll see that though per the age groups, also the incidence varies quite dramatically. So in our population, the 18 to 24 groups will only have 8.8 per 100 person years, whereas in the US it's only 2.2 in that similar age group, and in the above 35s at 5.3 and 1.3. So it's like almost a four times, we have a 4 time higher, 4 to 5 times higher incidence of this. So our flag actually flies high in vain there, guys. So locally, there is limited data, but there was a paper that we came across published by one of our own. It was done locally in a local tertiary hospital. And it looked at herpes simplex type 2 infection in pregnancy in our environment, and the prevalence and risk factors and co-infection with HIV. It was a cross-sectional study, looked at 248 women. It was done in August of 2017, and they found that the prevalence of HSV2 and HIV1 was 71% and 50%, respectively, with co-infection rate of 60%. And actually, new cases of HSV infection was thought to cause 50% of the new cases of HIV in the pregnancy, because they both increase the incidence of infection. So one increases the others, so they work hand in hand. In terms of risk factors, protected sex, high sexual partners, especially if they're anonymous, and having other sexually transmitted disease and being a female, and other things like anything that suppresses your immune system, such as stress, UV exposure, etc. All of these are risk factors. So the rest all. And if they come with symptoms for your oral infection, you have those severe oral mucosal swelling, flu-like symptoms, and it will be severe in the primary infection. In the labial, you have facial lesions, ulcerative painful stomatitis, fever, and maybe you could have malnutrition due to pain around your mouth, basically. In terms of a primary genital infection, it would present with papules, macules, vesicles, pustules, ulcers, inguinal adenopathy, systemic flu-like symptoms, pruritus, and dysuria. Your females are more likely to have ulcer formation, and your males are likely to have vesicles when they come through. Your non-primary HSV is less severe and would heal within less than 14 days and would just present with minor lesions. It's less painful, lower likelihood of complications. In terms of your viral replication, it can either be spontaneous or due to any physical stress or emotional stress, anything that suppresses your immune system. And your prodrome would essentially be characterized by pruritus, burning, pain, tingling, and irritation. So your oral outbreak would present basically in 6 stages, and this is basically typically what the HSV sort of virus follows. So over a 14-day span, you start off the first day with tingling, itching, burning beneath the skin where you get affected, and this is the time to actually start your treatment. So when you have that tingling and that prodrome that we call it, then you start. Then by the second day, you have small red bumps which begin to blister. And then the blisters would then fill up with fluid, and then you have that full scale so-called cold sore that we always see, or the herpes lesion, which is like crops of vesicles. And then by the third day, the blisters would rupture and they'll leave a shallow reddish wounds. And this is when the sore is actually most contagious by the third day. Then the lesions will collapse, leaving a yellow crust. The crust will then fall away, leaving a red tender area. And then within the span of the next up to 14 days, leading up to 14 days, then the irritation would fade and your immune system would get in control of the infection. It's similar in terms of the genital lesions. So the genital outbreak would be associated with fever, fatigue, headache, a vaginal discharge, pain around the genitals, a pain during urination, so dysuria, skin tingling, and you'd see something like what you're seeing there on the picture to the right when you examine the patient. So the issue is that it's a genital ulcer disease. So there's a whole host of differentials, but because we're talking about herpes, basically want to know how do we actually make a diagnosis of herpes, because you have such a long list of differentials that could be causing those ulcers. So in pregnancy, your first step would be to do a type-specific serology, which are necessary for classification, which we'll discuss in the next slide. You would unroof the vesicles, swab the vesicular fluid and base, and send it off for PCR and culture. So the patient would, if the patient had presented with genital ulcers without a history of herpes in the past, then you do those two steps for the patient to make a diagnosis. If it comes back negative, but you still have a strong clinical suspicion, then you wait for 3 to 4 weeks and you repeat the serology. If the serology is still no seroconversion, then it's unlikely that this is herpes. Similarly, if you have a history of genital ulcers and now you're presenting with an active ulcer without a history of being seropositive, you do your serology and your PCR and culture. If you don't have the first two available, then there is direct fluorescent antibody test that if the above tests are we The PCR is preferred because it's more sensitive than the culture, although the culture is more specific. We don't do the PCR just to identify asymptomatic viral shedding, except in research setting. So then you'd go on to classify the infection into three categories. Is it a primary, non-primary first episode, or recurrent episode? Where the primary is characterized by no pre-existing HSV serum antibodies. And this is the first occurrence of the lesions, and you picked up a particular virus in that lesion. Then non-primary first episode would be a case where you have pre-existing HSV serum antibodies that are present, but this is the first occurrence of the lesion with a different HSV that's picked up in that lesion. And then the recurrent would be the same HSV is picked up in the lesions as a pre-existing HSV serum antibody. So this is just a table, which is basically a clinical designation. Speaking of the same, so you have a particular HSV that you picked up, and then you check your serology. If you just picked up a virus, but you didn't pick up anything on your serology, then that's a primary infection. if you picked up a particular virus and another antibody is present in serologically, then that's a non-primary first episode. And then if you pick up a particular virus and then you have the same or both antibodies in your serology, then that's a recurrent infection. Okay, let's move on to look at the treatment modalities that are available. So just for everybody to be aware that there's multiple treatments that are described, like algae-based, fungi-based, plant-based, and nanotechnology-based, but these are not for the scope of this lecture. We will look at the synthetic-based, which are, because we're looking at herpes in pregnancy, which we will discuss. So synthetic treatments for antivirals for HSV were developed in the 1960s to restrict viral replication. The first drug was vidarabine, which was then discontinued about 4 or 5 years later. It was an anti-cancer drug, but it also had antiviral properties, but it had such a high adverse event and side effect profile, like thrombocytopenia and all other adverse events. So it was discontinued, and acyclovir took over. And acyclovir targets both HSV 1 and 2. And other drugs that are that are FDA approved include penciclovir, famciclovir, ganciclovir, bedacyclovir, and all these antiretrovirals are out there in the market. They shorten recovery of the infection by up to 2 days and reduce viral shedding. They have some issues like some side effects, and viral resistance is something that can occur, but they're otherwise generally good, accessible, tolerable, and effective. So in pregnancy, we give acyclovir 400 TDS for 7 to 10 days. The TDS dosing is informed by the high GFR, the increased GFR in pregnancy, hence rapid elimination of the drug. Remember that the acyclovir is metabolized minimally by the liver and actually is excreted in the urine almost unchanged. So that's why hence the TDS dosing. You don't need any clinical or lab monitoring to monitor these drugs. Valacyclovir is a PD dose, so it might have better adherence, but there's less efficacy data. But in clinical settings, it's been deemed to be safe. And basically, acyclovir takes the first line drug because it's safe in all stages of pregnancy and it's proven in animal and human studies. So the antivirals basically inhibit viral DNA polymerase from extending the virus genome during replication. The acyclovir is phosphorylated into acyclovir triphosphate intracellularly by a viral thymidine kinase, and then it's changed into acyclovir monophosphate to decrease the escape from the cell so that it continues exerting its effects longer within the cell. You have oral as well as topical agents that are available. Acyclovir, which we've discussed, valacyclovir has improved intestinal absorption. Penciclovir is quicker phosphorylation and therefore a longer half-life. Famciclovir is a prodrug which converts to penciclovir. And then to alleviate epithelial keratitis, you have your topical regimens where you have a variety of options. Acetop and Zovirax are some of the common and known topical creams. So your acyclovir and the rest of your antivirals some of them have topical, oral, and IV. Acyclovir in particular has all available, and they target HSV and varicella and CMV, etc. And to the right are the trade names, which will not dwell too much on that. The adverse events include GITI, upset, nausea, and vomiting, but tiredness is one that is frequently reported. And in the worst case, you can have nephrotoxicity, which would present with obstructive nephropathy, hematuria, pyuria, crystalluria, and some mental and mood changes, but these are uncommon. So we won't look at primary prevention because it's still under research, but those are the potential targets for HSV prevention, which are being studied. So moving on to vertical transmission. So the ultrasound features for congenital herpes include skin vesicles, chorioretinitis, microcephaly, microphthalmia, and fetal growth restriction. So basically, we know that direct contact with the virus that is shed from the infected site, such as the cervix, vagina, will then cause an ascending infection into the unborn. And the mode of delivery, duration of rupture of membranes, fetal scalp, electrode, and other invasive modalities will increase that risk. So in the case of non-primary or recurrent infection, there's less risk of transmission. Why? Because there's transplacental maternal neutralizing antibodies, which are protective to the fetus. But in primary, because these protective antibodies are not yet established, there's highest risk for infection, especially in the third trimester. So your congenital herpes is rare, but if it does occur, it will manifest with skin, eye, CNS manifestations and growth restriction, and in worst case, intrauterine death. We will look at some neonatal herpes later. Disseminated herpes is more common in preterms. We will look a little bit into that later as well. So some evidence around vertical transmission and the frequency of neonatal infection. So here Brown looked at a 2-case series. And they looked at the frequency of neonatal infections, and they found that with the case of primary HSV, there was 40 and 44% frequency in terms of neonatal infection compared to non-primary, where there was only 31 and 24%, and recurrent had the lowest frequency with 3 and 1%. And Tronstein looked at subclinical viral shedding, where they were measuring, where they were performing PCRs on women who are coming in to labor, and they wanted to see those that are symptomatic and asymptomatic, what was the rate that they were shedding the virus. And they found that those who are symptomatic had 30% viral shedding rate, and those who are asymptomatic had 9% viral. So it's like 4% difference, but you still have viral shedding even when you are asymptomatic. So your risk of continuing with the evidence around the risk of vertical transmission, Brown found that the cesarean delivery was protective, and your viral genital shedding was a strong predictor of neonatal HSV with an odds ratio of 346. They looked at 58,000 women, classified them for HSV using PCR culture and serology, and 202 of them isolated HSV at the time of labor. And 5% neonates had neonatal HSV, where 5% neonates where there was HSV, where the mother was HSV positive, developed neonatal HSV, and then 0.02% where the mother was HSV negative, developed neonatal HSV. So this is because some neonatal HSV is attained postpartum. So the highest risk for vertical transmission is higher in primary, as you can see here. So in the case of primary HSV infection, there was a rate of 54 per 100,000 live births versus 26 per 100,000 live births for HSV1 and 22 per 100,000 for HSV2 seropositive live births. So the primary infection had a higher rate of vertical transmission compared to the non-primary first episode. And isolation from the cervix, shedding of HSV1, invasive fetal monitoring, and delivering under 38 weeks, and maternal age of less than 29 had a higher odds ratio for a risk of vertical transmission, with isolation from the cervix having the highest odds ratio. Furthermore, they looked at 7,046 women who are HSV seronegative, which were observed throughout the pregnancy, and 94 of them went on to develop primary HSV, and 30% of them seroconverted in the first trimester, and 30% in the second, and 40% in the third. And of those, 44% neonates whose mothers had HSV shortly before labor um, had one of those neonates die. 7 out of 9 women had non-primary first episode, HSV1 antibody positive, HSV2 culture positive, and 2 of those were HSV positive at delivery. And 2 women had primary infection at delivery, where they cultured HSV1, and both of them transmitted HSV to their neonates. So seroconversion well before labor is not associated with perinatal morbidity because, as we mentioned, you already have developed those protective antibodies, and they take about 12 weeks to be established. So now looking into the management of herpes in pregnancy, let's start off with the screening. We don't universally screen our patients. But if a couple presents to you and they choose to be screened, then you want to do your type-specific serology. And if they are both negative, there's no action that's required. If a woman is negative and the partner is positive for HSV1 or 2, then you would advise for condoms, safe sex basically in the first 2 trimesters. And in the last trimester, you want to avoid any sexual or oral contact, and want to offer the male valociclovir 500 daily, which has been showed by Corey et al. To be 48% effective. So in the case of your primary and non-primary first episode of genital infection, you would start off your empiric antiviral therapy whilst you're waiting for your viral studies, which would be acyclovir 400 TDS, either orally or IV if it's a complicated infection with, for example, disseminated herpes, and then you'd give it for a duration of up to 10 days. But then you restart the suppression therapy at from 36 weeks till delivery, same dose 400 TDS of acyclovir. But if you feel that there's incomplete healing, then you can continue the treatment beyond 10 days. Or if the infection was attained beyond 28 weeks, then you just continue on till delivery, because from 28 weeks in the 3rd trimester, you can deliver the patient at any time, and you don't want to risk exposing you want to minimize the risks of neonatal herpes. So you'd also add analgesia and sitz baths, and basically by doing this, you reduce the duration, time, symptoms, and the viral shedding in maternal complications. In the case of recurrent infection, it has the lowest risk for neonatal herpes, even if the lesions are present at delivery, with 0 to 3% rates. So in this case, you just go for conservative management, saline and analgesia without acyclovir, and this usually would suffice. Because recurrent episodes last about 7 to 10 days, even without treatment, and they are very mild. So if you have severe or frequent attacks and the woman is actually desiring acyclovir, then you can give acyclovir, same dose as with primary. And an NVD is acceptable unless there's another obstetric indication for a Caesar. And you'd still resume your acyclovir from 36 weeks till delivery. There's no increased risk of congenital anomalies if you have recurrent genital herpes, according to most the evidence that's available. So suppressive therapy is as described, acyclovir 400 TDS from 36 weeks till delivery, and Holia et al. Found that it reduced the frequency, duration, and severity and recurrence of symptoms at labor onset. And also found that it reduces the need for a cesarean delivery, and it also reduces asymptomatic viral shedding at delivery, and therefore, hopefully, vertical transmission risk, although it doesn't completely eliminate the vertical transmission risk. Antepartum and obstetric procedures that you can perform. So cervical procedures such as cerclage and chorionic venous sampling should be avoided if you have active genital lesions. But if the patient is asymptomatic, then you can perform these. But transabdominal procedures such as amniocentesis, fetal blood sampling can be done even if you have active infection. So in terms of the Caesar protectiveness, so Caesar does not completely eradicate the risk of transmission, but it radically reduces it, as Brown found when they looked at 58,000 women, of which 202 had genital HSV isolated during labor. 5% of these women, which is 10 out of the 202, had neonates which developed HSV. And the NVD, the Caesar portion of these neonates was only 1%, which is 1 out of 85. And those who had NVD, 7.7%, which is 9 out of 117. So you can see that those who had the NVD had a higher rate of neonatal HSV, and the Caesar was less, but it was still there nonetheless. And Stone et al. Looked at the national surveillance study where they found that 15 out of 184 developed neonatal HSV despite Caesar, even prior rupture of membranes. So at the best set of circumstances to prevent, still you had 15 out of 184. So you will have those patients. But it has been found that if your serum IgG antibodies are present, then there is no indication for a Caesar to prevent infection. So during labor, you want to avoid anything that causes breakage of fetal skin. If there's history of HSV, as we understand that even when you're asymptomatic, you still can be viral shedding. Therefore, there's still a risk of neonatal HSV. So you want to minimize things like vacuum fetal scalp electrode forceps if you can. In the case of primary infection around the time of labor, then a Caesar is recommended. But if you opt for a vaginal delivery, then you must cover the woman with acyclovir 5 milligrams per kg 8 hourly for the mother, and the baby would then get 20 milligrams per kg 8 hourly, which is 60 milligrams per day after they are born. In the case of a recurrent infection, then the risk of transmission is very low, as we've mentioned earlier on. So some unique situations that you might come across are a case where you have PPROM and active HSV. So in this case, if it's a recurrent HSV, then and it's the second trimester, expectant management is acceptable. And if you have recurrent infection in the third trimester, then you need to weigh the risk of prematurity versus the risk of in utero infection case by case. For example, if there's higher risk of, let's say, chorioamnionitis, for example, you might need to expedite the delivery. These women would then need to be given IV acyclovir 500 milligrams 8 hourly to decrease the viral burden and duration of active lesions. But note that acyclovir does not guarantee prevention of maternal to fetal transmission. Manuk found that the maximum risk for neonatal HSV in the setting of pre-prom and HSV is lower than the risk of major prematurity morbidity. Basically, there's a higher risk for neonatal prematurity complications than actually getting neonatal HSV in the case where they're occurring at the same time, especially with your recurrent. With your primary or first episode non-primary, there's limited data, but some sources suggest that above 28 or above 32 weeks, then they would advocate for a cesarean section, and then to treat the neonate subsequently with acyclovir and surfactant in nursery. But if the pregnancy is below this range, then the complications of prematurity outweigh the risk of infection. So you would do a Caesar if a Caesar is recommended if delivery is ensued within less than 6 weeks of the onset of the symptoms, regardless of the duration of the rupture of membranes. In the case of an HIV positive mother with HSV infection, and it's a primary HSV infection, then and they come in the third trimester, you manage them as per all women with primary infection. But in the case of recurrent HSV, then here you then start your daily suppressive therapy, not at 36 weeks, but at 32 weeks, especially if you have a planned NVD. And this is because there's increased risk of preterm labor, and hence you have to go for earlier suppression therapy. Disseminated herpes in the mother. So they would present to you with encephalitis, hepatitis, skin lesions, which are termed eczema hepaticum, which is very rare, such as seen in the picture to the right. We have extensive herpes simplex lesions, and only in the immunocompromised is this risk increased. In the immunocompetent, it's very rare. The risk of mortality with disseminated herpes in the mother is very high. And co-infection of HSV and HIV increases replication of both the viruses. So in the postpartum period, you want to ensure that you always have your peds involved and informed. Note that 15% of neonatal herpes is acquired after birth from a family member. So keep your family members away from the babies if possible. Anyone with active lesions in particular, regardless of the site, should be careful when handling infants. They should make sure that they wash their hands, observe the universal protocols for infection prevention. Breastfeeding is not contraindicated, provided that there are no herpetic or breast lesions. And acyclovir and valacyclovir are still your go-to drugs, even during breastfeeding. In terms of neonatal herpes, we are approaching the end. So they would present with localized manifestations which are skin, eye, and mouth, also termed SEM. And this accounts for 30% of presentations of neonatal herpes. And with the use of antivirals in these babies, the mortality goes right down to below 2% with a good prognosis. As far as those who present with local CNS disease, such as encephalitis and seizures, the issue with these is that they usually present late, after 10 days, up to even 4 weeks after birth. That's when they would present. And with the use of antivirals in these babies, then the mortality can be as low as 6%. But you do have lifelong neurology of up to 70%. And then with your disseminated infection with multi-organ involvement, this entails the worst prognosis. And with the use of antivirals, the mortality can be 30% and 17% long-term neurology. So your neonatal herpes would present in one of these three categories, either local skin, local CNS, or disseminated infection and multiple organ involvement. So this is just a picture showing neonate with those HSV lesions in the arm and also in the scalp area. So here, Kimberlin et al. Looked at the different presenting signs of neonatal herpes. And you can see, for example, that vesicles are most prevalent with your skin, eye, and mouth manifestations, so your local symptoms. And seizures are more common with your central nervous manifestations. And DIC, for example, your coagulopathies are almost exclusively associated with your disseminated herpes, neonatal herpes. So to prevent the infection in the postnatal period, you just ensure good hygiene and you educate the mother about the danger signs, to be alert about when they go home, to avoid kissing the baby, as 25% source of neonatal herpes is actually from a close relative, not anybody distant. So in terms of just a summary by the RCOG for the management, so you differentiate your herpes into: is it a recurrent genital? Is it a primary acquisition in the first to second trimester? Is it a primary acquisition in the third trimester? So for all the entities, then you'll treat them with your standard dose of acyclovir as necessary if it's recurrent. With your first and second trimester primary acquisition, you treat them with your standard dose acyclovir, as we've discussed. And in the third trimester, you do the same. And then with your recurrent and primary in the first and second trimester, you then do your acyclovir, your suppression therapy from 36 weeks, 400 TDS. And with your primary acquisition in the third trimester, you will consider actually continuing the acyclovir till delivery. You don't wait to start at 36 weeks. And then with your primary acquisition of genital herpes in the third trimester, a Caesar is recommended if delivery is within 6 weeks of manifestations. And then in terms of your recurrent, you would offer your vaginal delivery and normal postnatal care thereafter. With your primary acquisition in the third trimester, you would offer a Caesar, but if they decide to go for an NVD, then remember you give that intravenous acyclovir, and then you get your neonatologist involved, and the baby would be assessed post-delivery and treated with 20 milligrams per kg TDS for 10 days whilst awaiting the results. If they are unwell, then they would be worked up for like with lumbar puncture and PCR. And then all of these women, you always involve the neonatologist. The postnatal care is a normal postnatal care otherwise. It just depends on how the baby was doing. So this is just a nice summary of the approach algorithm there. So in summary, we're saying that vertical transmission is a great concern in pregnancy. We are saying that we need to classify the women into primary, non-primary, and recurrent. We make a diagnosis by doing a viral test on the lesions and serology. Vertical transmission occurs by direct contact, even when the woman is asymptomatic and there are no lesions. The highest risk of transmission is with your primary episodes, and especially during the onset of the time of labor and with invasive procedures. Empiric treatment is recommended if there's a new ulcer during pregnancy. Acyclovir is a safe drug to use in pregnancy throughout all the stages of pregnancy, and the dose is as we've described. And recurrent episodes do not actually warrant treatment. And we are saying that a cesarean delivery can decrease, but not eliminate the risk of neonatal herpes, HSV. Active HSV in the setting of PPROM requires a risk-benefit assessment regarding prematurity versus neonatal infection. In the case of PPROM and recurrent HSV, you can go for expectant management and your lung maturity, give your IV acyclovir. And in the case of your primary infection, in the background of PPROM, then if that is below the 32 mark, then there's limited data. But the risk of prematurity seems in most available data to be higher than neonatal infection. And if closer to term or within 6 weeks of onset, then we would suggest an emergency Caesar. So now the closing remarks, HSV infection in pregnancy can be subclinical, can be associated with physical and psychosocial morbidity. Clinical suspicion should be confirmed with laboratory testing, and management is tailored to the individual patient. Counseling about clinical manifestations and prevention of transmission and relationship with HSV and HIV should be explained to the patient, and the partners should always be involved because they are the ones who are passing it on to the women, and the women are quick to receive it. So in those words then, I'd like to thank you.
Thank you so much, Dr. Zita, for that comprehensive overview. We're going to take some questions now. We'll start by giving an opportunity to the people that are online to ask whatever questions that they need to be clarified. I'm sorry we took so long, but finally we got there. Any questions from those online? Yes, Dr. Abineza.
Good morning. Thank you for the presentation. I think I might have lost, I'm not getting it. Just please, can you simplify the management of asymptomatic women and pregnancy with seropositive? In other words, common scenario is where someone has a down throat in a patient with polyhydramnios, but they have no clinical features, no lesions. How do you manage that patient when the serology comes back positive?
Yeah. So when you say the serology came back positive, which part of it is it the IgG or IgM?
No. In this case, I'm talking about IgM. So and you probably also would get a scenario where you had both positive, but specifically when IgM is positive, HSV IgM.
Yeah. In such case, I think it's quite difficult, to say whether it's a primary or a secondary infection. Yeah, because in order for you to be able to classify whether it's a primary or secondary infection, you would want to see, like you said in the presentation, if the patient has got a lesion, you have to do a culture from there, and then you also have to, look at whether the type-specific antibodies that are being picked up, they relate with the virus that is picked up from the lesion. So in a case where you just having the IgM antibodies, I think it will be quite difficult for you to say whether this is a primary or a secondary infection directly just from that. So I suppose if we have that difficulty, we should veer towards managing it as a primary infection. Unfortunately, I think that's what I would do if I'm presented with such case. I don't know whether anyone has any contrary view to that, but yeah, I think that's what I'm going to do.
Well, I think obviously the critical part is that how do you deliver the patient? And obviously, it's an issue of history. I mean, have you had these things before? Or never had it before? Just finding an IgM, it says in the patient with polyhydramnios, where they investigate polyhydramnios, and they suddenly pick up the antibodies. Now, the patient has not had a lesion. Either she has had lesions in the past, or she doesn't have, she has not had a lesion in the past. If she has had lesions in the past, obviously, it depends whether that was the first episode that she had, or the number of lesions in the past. That's how history will guide you as to whether this is a primary issue. Because you want to say if it's primary, how long ago before the time of delivery is this primary, has the primary event occurred? And the 6 weeks is the one that's buried around into that. But if the patient has had previous episode outside pregnancy and in pregnancy, it's no longer primary. It's obviously a recurrent kind of regional assault. When you come to delivery to say, if there's not a 6-week issue and a primary issue, then the patient will have an NPD in the straightforward as that. Unless the patient has got active lesion at the time of labor.
Did you get that, Dr. Habineza?
Yes, thank you.
Okay. Have you got any other follow-up questions? Any other question from those online? Okay. If we don't have any further questions from those online, we will come to the floor. Any questions from those on the floor?
Okay. Thank you, Dr. Stephen, for a very complicated presentation. So I was slightly confused. Can you just clarify the difference between primary episode, primary first episode, and a non-primary first episode? And are there any differences in the management in those two?
So yeah, so primary episode, you don't have any pre-existing HSV. And you serum antibodies, and this is the first occurrence of a lesion, and you pick up a particular HSV in the lesion that you sent. Yeah, so basically your primary episode, you have a patient, she presents with the lesions, the first time that she's coming in with this lesion, and then you send off serology and a culture for PCR from the lesion, because you have to deal with the lesion and send off a PCR and culture for that lesion, and then you send off your serology to get your antibodies. And then the results will come back and they will show that the antibodies are negative. But there's HSV either 1 or 2 picked up from the lesion. So that's a primary
What
lesion.
about
Sorry?
patient's positive IgM? Is that primary or is it not primary?
So the IgM is representing so basically with the primary episode, you won't have any serum antibodies that will be positive.
Don't the IgM come early after an infection? So by the time the person comes and presents, yes, they've already IgM.
Sorry, let me just come in here. Now, when in doing the classification, what they use is IgG antibodies in doing the classification to see whether it's actually a primary, or a non-primary or a recurrent infection. What they use is IgG, not the IgM antibodies.
Is it clinically they're both the same, primary and non-primary first episode? This is the first episode. The difference is that in the non-primary, the person's already got antibodies. In terms of the management, is there a difference?
Now, the risk with the primary, it's more than the risk in the non-primary first episode. So I guess you would use case by you would manage it case by case, because like he presented, the risk of neonatal transmission in the primary infection is up to 41%, but with the non-primary first episode is about 31%. So I guess you would manage it case by case as it presents. You would use that risk to stratify the management you would give the patient. Now, if you're looking at a patient that is coming in the third trimester, for example, and that infection is within 6 weeks of the delivery, with the non-primary first episode, I think it will be reasonable for you to offer that patient is cesarean section, because 31% is actually a very high risk. Yeah.
So basically, if the lesion was not in the third trimester, it really doesn't matter whether it's primary or secondary. In terms of managing the patient, it's only of value that information if you are in the third trimester, because you got the 6 week story, and then you was considered, unless you got an active lesion that you see. So,
Any further questions? Still have some more questions?
So, when you have a child who's got cerebral palsy, you do investigations to try to identify the cause. One of the possible causes would be congenital HS infection. That's the chemical and you mentioned that type of neonatal infection which is affecting the brain. Is there a particular type of brain lesion that you can relate to HSV infection, which will be useful in trying to determine? Because usually we're working back from a child who comes at 2 years of age or then also with it. Is there a particular type of brain lesion that might be typical for the type of injury that might be caused by HSV compared to hypoxia with labor?
I'm not sure about that. We did not go that far with our research when we're preparing for the topic. But I guess we will do well by inquiring from our neonatal and pediatric colleagues if they exist such a lesion that is in keeping with herpes simplex infection. But insofar as this presentation is concerned, we did not go that far. Anyone who knows can help us with that.
outside of some example.
Yeah.
It's a discussion of the people that look at the baby and the baby will that they would know that.
Yes, I agree. But it might be important for the obstetrician if they're trying to defend themselves against an accusation that they caused the problem by mismanaging the labor, when actually it might have been an infection that's possible.
Yeah, what I'm saying, the details of that, I don't think they know. She would know. I think when the case does arise, then the incident is done. After that, but I mean, ours is to prevent your infection. If anything happens after that, then obviously that people that will be confident in knowing that are usually the neonatologists and the pediatricians, which are the sort of
Yeah. Okay.
Just one last point.
Okay.
I think you made some comment of this in term, but you must, if you do end up doing a vaginal delivery, in a patient who's got herpes or active herpes, you should be careful to avoid some kind of procedure that will cause a breach in the skin of the fetus. Yes, that's a correct comment, but I think one should caution before saying you mustn't do a vacuum, because you usually do a vacuum either because there's prolonged second stage or to prevent prolonged second stage. But if you don't do it in that situation, you're going to leave the baby's heads sitting in a vagina full of herpes for a longer period, which I'm not sure that avoiding the vacuum in that situation would actually going to reduce the transmission. One might reduce the transmission is to reduce the duration of the second stage. So I think the vacuum is controllable. You can actually thoroughly rinse the area of the head, which you're going to apply the cup to, and you can also rinse it after removing the cup. But I'm not saying you must do a vacuum, but I'm just saying I think one should be careful before making statements like that, because you may end up doing a prolonged second stage where the head is there in amongst the herpes lesions. It might be better to make the second stage short. This is of course in a situation where for some reason you haven't done a Caesar, you're not able to do a Caesar.
Yeah, the high risk is when you have like a breach in your mucosa. So anything that will breach your mucosa will actually increase your risk. So that's why I was saying that if you can avoid it, avoid it. But obviously, if there's an indication, because remember, you can even get neonatal herpes, even in the best circumstance where you did a Caesar before even rupture of membranes and still get. So obviously at NVD, there is that exposure. But if you do something invasive, then you're actually increasing the risk of neonatal transmission. But if you have to do it, you will do it, obviously, because if it's obstetrically indicated at that moment. But if you can avoid it, rather avoid anything invasive. Yeah.
So just to add to the point that he's making, I think the risk with those instrumentations is actually more with primary infections. You know, with recurrent infections, the overall risk, irrespective of whatever you do, is 0 to 3%. You know, so you need to put that into consideration when you are deciding whether to do instrumentation or not. If it's a recurrent infection, of course, the benefit of doing a vacuum would outweigh the risk of you giving the patient infection. But if it's a primary infection that occurs close to the delivery of the patient, then you really need to think very carefully before you proceed with any instrumentation. Okay. Any further questions? Oh, okay. Thank you so much.
Recording stopped.
I think Sean is taking you're giving the feedback. Just